Okay, guys, we will be beginning now. So, just before we begin and talk about herpes, how many of you all have actually read this before or have gone through a bit of, what is herpes? Anyone? Okay, easier question still then. What is the virus that causes herpes? You all can type it in the chat box, please. We have today with us Dr. Leila, Nada, Nema, Dr. Shova. Any guesses what causes herpes? Okay. So thank you so much for waiting, guys. We'll be beginning now. So as I said, what is the cause? You're right. It is herpes simplex virus. It's herpes simplex virus 1 and virus 2. And both of it can cause infection. It is commonly known that HSV1 causes infection around the mouth, that is cold sores. And the genital infection is, however, is said to be more common with HSV2, right? But let's look at the data and what this guideline is telling us. So this is in 2024 that has been updated in October 2024, how to manage herpes in pregnancy. Now, why this is important to us is that, okay, for a mother, getting herpes is not a big deal, right? Because we can manage it with with antivirals, with proper local care. However, it's more harmful for the baby, especially if the infection is around delivery, right? So herein we have to talk about both the mother and the baby. Now, to understand, neonatal herpes is rare and serious. It has been classified depending upon the involvement of the lesions or areas of the baby. Now, first of all, the most common one and the one with a good prognosis is the skin, eye, and mouth area being involved. So, this is just something that is superficial. It's called as SEM. It's abbreviated to SEM. That means skin, eyes, and mouth. And that is present in around 32% of babies. And it has good prognosis because in such cases, the mortality is almost zero. Okay? The mortality is almost zero when treatment is given. And its neurological or ocular morbidity is only 6%. So SEM is something that is still okay. But what is scarier becomes the local CNS and disseminated disease in the baby. The local CNS disease could only have either just CNS involvement or with or without skin, eye, and mouth lesions. It is seen in 35% of babies, and on treatment, its mortality is still 15%. Disseminated is basically widespread, and that is around 33%. And its mortality, even on treatment, is very high, that is 66%. This mortality is neonatal mortality because we're just talking about neonates here. Why it is important to read herpes? Herpes is mainly affecting the baby, especially during delivery. Further, when all can the spread of the virus can occur to the baby. 85% can occur during birth, that is during the parturition process. Immediate postnatally, 10%, 10 to 20% is by either by breastfeeding or by postnatal. Postnatal could even be contact with the, like if the patient has cold sores, or if her through, fomites, and not fomites, by touching. So this can also cause postnatally. Postnatally, you might get it from another relative as well. It's not necessary that the mother would have the infection. For example, a relative is come to see the baby, and that relative has herpes. It can spread to the baby postnatal. And very rarely in utero, it's only 5%, and that can cause congenital herpes. The So the recent guideline states that the overall neonatal mortality is around 24%. Please remember these numbers. All the numbers that I've highlighted in today's session are SBAs. Okay. Neonatal herpes, as I said, can be with herpes simplex virus 1 or virus 2. And virus 1 is around 52%, and virus 2 is 48%. That is the amount it can get. It's the incidence of this particular virus in herpes neonatal infection. Now, here's a picture which basically shows the typical lesions of herpes. They are vesicles, fluid-filled vesicles, which can burst and even crust. You can see that they are beginning to crust. Am I clear so far, guys? Am I making sense? These numbers might be a bit tricky, but you all need to remember them. Okay? Do you all have any questions so far? Because I'm going to go slow. I want you all to understand it and retain it into your memory today itself. So if any questions, please put it in the chat box. Okay? Now, the infection of genital herpes. So what happens is, when there's genital herpes, we classify it as first initial episode. Initial episode is first episode with either HSV1 or HSV2. This depends on whether the individual has prior exposure or not. Primary infection is when first infection with either HSV1 or HSV2 in an individual with no pre-existing antibodies to either type. Non-primary infection means first infection with either HSV1 or HSV2 in an individual with pre-existing antibodies to the other type. For example, there's a patient who's had HSV1. Okay, all of this is something that we understand on viral PCR, the type of the virus, right? So if there's HSV1, let's say she's come to you and she said that yes, she has herpes lesions on her genital areas right now, and she says that in the past as well she's had herpes, but she says, okay, maybe I've had it around her lips, right? So you test her IgG and you come to find out that she has HSV1 antibodies, and then you do the viral PCR comes from the lesions, and that's HSV2. So that becomes non-primary infection because she does have antibodies, but that's for the other type of the virus. Recurrent episodes means recurrence of clinical symptoms due to reactivation of pre-existing HSV1 or HSV2. And they will basically have the same type of virus and recurrent. Like, for example, she's had past genital sores, that's with HSV2. And then again, we tested and she says that, yes, I've had HSV2 and maybe I've had genital herpes before, like 2 years ago. And now again, she comes with the genital lesions. And then you understand that, okay, this is both the same lesion. Then you can definitely call it recurrent herpes. The highest risk of transmission, this is very important, is that the highest risk of transmission to the baby is when the mother develops it within the third trimester, especially within 6 weeks of delivery. That means she does not have enough protective antibodies for the baby to have. For example, a patient delivers around, let's say, 38 weeks and she's had herpes for the past 1 week. So she becomes someone who's at a very high risk of transmitting the disease to the baby. 32% babies with neonatal herpes are born less than 37 weeks. So the recent change in the guideline is that it has moved its antibiotic prophylaxis from 36 weeks to 32 weeks. We will be elaborating this a bit further, but understand this, that whenever we start as a suppressive dose, we started from 32 weeks. Okay. Now in adults, In adults, how does it present? Usually, herpes will present as vesicle-filled lesions on the labia. Sometimes they can present with fever, malaise. Very rarely, she can have, because of the pain, she can have acute retention of urine. All of these cases would present in an adult. This is an immunocompetent adult. When the patient is immunocompromised, for example, she is a known case of HIV, or she's on a long-term corticosteroid, or she's a transplant patient, or she's on immunosuppressants, then she becomes someone who's immunocompromised. And immunocompromised patients can present with worse prognosis, like they can present with disseminated herpes. Disseminated herpes can either have, CNS involvement, they can present as encephalitis, meningitis, or in general sepsis as well. Women who have HIV and have concurrent infection with HSV, they say that there's an increased risk of transmission of both HIV as well as HSV, right? So especially women who are seropositive, we have for HIV, we have to be very careful because there's an increased risk of transmitting both. So she has to continue the antiretroviral therapy and she has to be careful about the HSV as well. So we have to give her the acyclovir. Also, the antiviral that we can use for herpes is acyclovir or valcyclovir. Famciclovir is not preferred. Now, if a patient presents to you, this is from the new guideline, and we consider that she is having, from her symptoms and on clinical assessment, we think that she has disseminated HSV and she's unwell and presents with a sepsis-like illness or picture with deranged or worsening LFTs, you have to consider that yes, she can have disseminated HSV. Send samples of blood, skin lesions, cerebrospinal fluid, and relevant bodily fluids for urgent HSV PCR as well as HSV IgG. We have to commence IV acyclovir at least 10 mg per kg 3 times a day. There's also an important consideration that you have to give for a renal function and other relevant comorbidities. This patient should be in an intensive care unit or a high dependency unit, and this has to be managed by a MDT, which will involve the intensivist, the microbiologist, the virologist, as well as the infectious disease specialist. Urgently inform the neonatal team because the baby also becomes a high risk for herpes. Now, any woman who presents to you, okay, this is in general, care to be given for a woman who presents with herpes and is pregnant. A careful history has to be taken so as to make sure that if she, to rule out a recurrent episode, if she says that no, she is someone who's had herpes before or has been treated for herpes before, then you know that this could be a recurrent infection or a non-primary infection. Mothers and pregnant women who've presented with herpes, it is very important to get a genitourinary medicine physician involved because they will help in diagnosing that the herpes infection, help in management of it, and also women who present with herpes are also given an option for sexually transmitted infection screening. That is, a whole STI screening is offered to them. Polymerase chain reaction testing from ulcers should routinely include, like there will be ulcers, right? So the ulcer, what we have to do is we have to take the PCR from the ulcer. Okay. Here we will understand what type it is, if it is HSV1 or HSV2. So type specific HSV determination can be done by doing polymerase chain reaction. Varicella zoster virus and Treponema pallidum for syphilis because they will present with ulcers, right? So to ascertain what will we do, we will do HSV, varicella, and syphilis. Wherever available, we can also do enterovirus and depending on risk factor, Mpox and LGV, that is lymphogranuloma venereum. Full STI screen involves what? It involves hepatitis B, hepatitis C, chlamydia, gonorrhea, syphilis, and HIV, depending upon the risk factors. Okay. So please remember this. Basic, at least, what do we give? We give chlamydia, gonorrhea, HIV, syphilis, and in women who have high risk factors, we can also give hepatitis B and hepatitis C. And obviously, in pregnant women, we would definitely be screening for that. In a woman who we think that a presumptive diagnosis of herpes is there, we don't wait for the results. And why is that? Because these results can take weeks together. So here we would rather start her on acyclovir 400 mg 3 times a day for 5 days. So how do you remember this? You remember this as 4, 3, 5. The other one is valcyclovir, which is 500 mg 2 times a day for 5 days. If patient presents as disseminated herpes, then what do we do? In disseminated herpes, as I said, intravenous high dose acyclovir, that is 10 mg per kg according to the body weight, can be started. And that is at least to be given 3 times in a day. This is in general how you would manage a patient who comes to you with herpes. So whenever you come, when now let's say we have a pregnant woman who comes to you, you take her history, you do her investigations, you take her swabs, you refer her to the gum clinic, you refer her for the physician. If she has any acute retention or anything like that, you do appropriate treatment. Then you start the acyclovir and you formulate her delivery plan, because our mode of delivery will depend upon what gestational age she is, right? Now, women who have, most of them who have the first episode can also have painful lesions. So here what we can do is we can offer them paracetamol, that is a painkiller, and topical lidocaine, that is for the ulcers, 2% gel. Please make a note of this. This is a SBA, and 5% ointment. For all mothers and pregnant women who have a high risk of preterm delivery, what we could do is we could also start acyclovir 400 mg twice a day from 22 weeks of gestation, followed by acyclovir 400 mg 3 times a day from 32 weeks of gestation. For example, now you have let's say MCDA twins, IVF conception with a short cervix with cerclage in place. She's someone who will have a high risk for preterm delivery. So in such cases, and she's a known case of herpes, right? She's been diagnosed as herpes, then you can even start. So what we usually do is we give it 5 days and then we again start it from 32 weeks. But in such cases, what we do is you would rather give from 22 weeks onwards. This is something that is new in this guideline, guys. Please make a note of this. Am I making sense to you? Please give me a thumbs up if you have understood so far. Okay, guys, I'm glad you'll have understood so far. So I'm gonna go over quickly again. I'm gonna ask you all some questions, and let's do that. A patient comes to you. I'm not telling you all the gestational week right now, but what are the basic tests that you all would send? Okay, I'm not talking about the STI screening. I'm talking about what you would send from the ulcers. Please, guys, type it in the chat box. There are just 3, 4 that you all need to know properly. It's any lesion that it's an ulcer in her genital region. So what are we sending? I want you all to remember the guidelines, so I'm going to revise as I teach. So please just type in, even if you're wrong, that's completely fine because we're here to make mistakes and learn from them. Okay, so what do we send? We send viral PCR for HSV 1 and 2 both, varicella zoster, and we also send syphilis. And whenever there are facilities and if risk factors say, then mpox and lymphogranuloma granular. Okay, and obviously, then we would send for a gum physician, do the STI screening, give her local treatment, paracetamol, and then give her cyclovir according to her gestational age and if it is recurrent or if it's a primary infection. Now, what are the different factors affecting transmission of HSV? First of all, it is the type of infection. That is, if it is primary or it is recurrent, right? Primary has a higher risk and recurrent has a lower risk. Why is that? Why? Because there is presence of antibodies in patients who have recurrent herpes. If you all remember, when we contract an infection, the first IgG that is the first immunoglobulin that is produced is IgM. IgM is a pentameric antibody. It has a very big structure. It does not cross the placenta. However, eventually, when there's seroconversion, IgM gets converted to IgG, right? So that is why we have the 6-week period wherein that would take for the seroconversion. And again, if it is a recurrent infection with the same serotype, right, then we would also have IgG because in subsequent infections, because of the memory T cells, we usually have IgG antibodies. If there's rupture of membrane, for example, a patient who is a known case of herpes and she comes with SROM or PPROM, then in such cases, there's a high risk that the more the duration, the higher the risk of transmitting the infection. And again, if a patient does not have ruptured membranes, then the risk is lower compared to someone who would have ruptured membranes. Use of fetal scalp electrodes and also the mode of delivery. Cesarean section would have lesser risk. Why is that again? That is because when the baby passes through the vagina, it's coming in contact with the secretions and everything. Whereas in cesarean, the baby is not coming in contact with the lesions itself, right? So that is why the mode of delivery also will affect it. Now, primary herpes. Now, we will be talking about according to the gestational age. Please, guys, if you're making notes or you're listening, please just be aware about this now. Yeah. So what they say is that for primary herpes in less than 28 weeks of gestation, that means that she's had that infection either in her first trimester or the second trimester. Okay. Then, as I said, the whole management plan that we did before, that we do a history, we send the swabs, we send the viral PCR, we refer to gum, we give treatment, we give local treatment, and we give a cyclovir. That remains, right? There's an additional point is that women who've had herpes can also be said that it's better to avoid sex in the third trimester because that can also worsen. That can increase her risk of having the transmission of the virus from the partner or. And another thing is that we don't know if the virus that she gets could be the same serotype that she had in the first or second trimester. For example, she's had like a HSV2 in the second trimester in around 20 weeks, and in third trimester she presents. But however, that's HSV1, right? Because it's not, the immunity is always different. It's specific, it's type specific, right? So in such a case, we would want her to avoid sex. Now, if she has, if there's primary herpes, let's say at 26 weeks, and she goes into labor at around, let's say 31 weeks, okay, she has a SROM. And we know that she's had primary herpes at 26 weeks, right? 26 weeks to 31 weeks is 5 weeks. And we're not really sure if the maternal antibodies have developed by now. So in such a scenario, we can offer her a cesarean section, right? But if the delivery is not imminent in 6 weeks, like we know she's going to go to term, right? Let's say low risk primary gravida had herpes HSV in 20 weeks. And now she's at 34, 35 weeks and she's fine completely. And there's no risk of going into preterm labor and already 6 weeks have passed. Then we would rather wait and watch for a vaginal delivery. Okay. So what happens is that in primary herpes, especially around 6 weeks time, if it is contracted in the third trimester, there is a risk of 41% of transmission. Or if even it's in the first or second trimester and the delivery is within 6 weeks, 41% chance of transmission to the baby, right? Especially in T3, but also if she's in T1 and T2 and goes into labor. Am I making sense to you guys? Understand that for primary herpes, there's a risk of 41% transmission, right? Um, if she's less than 28 weeks, what do we do next? Before that, we have to understand that there's no increased risk of spontaneous miscarriage with primary genital herpes in the first trimester. Suspected genital herpes, as I said, you refer to gum physician, viral PCR, screen for STI. Do not delay treatment. This is another important thing that you have to remember. We never delay treatment because PCR takes a long time to come. Now, someone who is a primary herpes less than 28 weeks, that is 27 plus 6, what would we do? We would give oral acyclovir, 400 mg, 3 times a day for 5 days. What acyclovir does is it reduces the duration of the disease, it reduces the viral shedding and also the chance of needing a cesarean section. We give 4-3-5. So less than 28 weeks, we give acyclovir 400 mg 3 times a day for 5 days. Or in the guideline, they've also added valacyclovir, which is 500 mg, 2 times a day for 5 days. Okay, this is valacyclovir. Okay. Next is again the local treatment, that is with paracetamol, lidocaine 2% gel or 5% ointment, that is for symptomatic treatment. And this is the change here, that is a daily suppressive dose. We begin from 32 weeks. Okay. Here we will have expectant management. We would go for a vaginal delivery. We can either give acyclovir or we can even give valacyclovir, the same dose, that is 500 mg twice a day. Okay. Now, acyclovir, acyclovir is basically not licensed in pregnancy, but it is safe. It is not associated with congenital anomalies. Suppressive dose reduces the HSV lesions at term and need for delivery by cesarean section. Also been shown to reduce asymptomatic viral shedding. Valacyclovir can be used, and as I already said, IV acyclovir to be used in disseminated cases. Did I make sense till now, guys? Give me a quick thumbs up if you'll have understood. This is primary herpes less than 28 weeks. That is first trimester and second trimester. Give me a quick thumbs up if you'll have understood. Yes.
Doctor, your mic is off. We can't hear anything.
Oh, am I audible now, guys?
Yes.
Yes. So we spoke about primary herpes before 28 weeks. Now we're talking about primary herpes in the third trimester. So in the third trimester, what happens is that we know that she could be near delivery and the antibodies could not be formed and given to the baby through the placenta. So herein we do a suppressive dose, right? So that means what do? We do 400 mg 3 times a day till delivery. And mode of delivery here especially is LSCS. And especially again, if it is within 6 weeks of delivery. The same treatment, that is paracetamol and lidocaine. As I said, transmission risk is as high as 41%. So this is 4-3-D. Okay? 4-3-D till delivery. Acyclovir 400 mg 3 times a day till delivery. Dr. Khadija has a question. So the initial part that I mentioned, I'll take you all to that slide. Yeah, here. So for any mothers who have a higher risk of going into preterm labor, right? And she has herpes. Okay. So here what we can do is that we can start acyclovir 400 mg twice a day from 22 weeks. This is the suppressive dose, guys, right? And so in a woman, let's say she's had recurrent herpes and we want to start the suppressive dose. We would usually start it from 32 weeks, okay? But in patients who have higher risk of delivery, we give a lower dose of acyclovir from 22 weeks, that is 400 mg twice a day from 22 weeks, and then switch over to 400 mg 3 times a day at 32 weeks till delivery. Okay? I hope this answers your question, Dr. Khadija. Okay, so primary herpes, as I said, after 28 weeks, she is 4-3D. LSCS is the choice that we would give her because 41% risk to do the symptomatic treatment. Now we have to tell her that it is difficult to distinguish clinically between primary and recurrent herpes infection, as 15% of cases present with the first episode of clinical HSV infection, but in actuality, it is a recurrent episode. Women developing first episode within 6 weeks do a type-specific IgG. If same antibody is present at genital swab, then this could be a recurrent infection. So what do? We know that she's, so we always do a type-specific. Whenever we do her, she presents with herpes, we do a IgG, right? And we do the viral swabs and we do type-specific IgG as well. Now here, if she is, let's say, immune to HSV1 and the genital swab is also showing HSV1, then we say that it is a recurrent infection. But tests are time consuming and can take 2 to 3 weeks. Thus, most of the times, if she presents after 28 weeks, we would assume that she is a primary infection and start her on treatment accordingly. That is 4-3D. Okay. Whenever the reports come, we have to involve the gum physician and the virologist. Now, I hope I'm clear till now. Let's just quickly go over it. Less than 28 weeks, 4-3-5, and from 32 weeks, 4-3D. That is acyclovir. And if she's after 28 weeks, 4-3D. That is 400 mg 3 times a day till delivery. And cesarean. Whereas for less than 28 weeks, we would go for a vaginal delivery because they get the antibodies and the suppression till then. Okay. Now, next we'll be talking about is herpes in a recurrent case of herpes. Risk of neonatal herpes to be transmitted, like for example, transmission due with recurrent episode is low. It's almost 0 to 3% from vaginal, even from vaginal deliveries. Treat with, now she comes to you, and I'll just give you an example. She comes to you she says that I've had episodes in the past as well. You do the test and you understand that after 2 to 3 weeks she is recurrent herpes. So what do we do is that we will be giving her 4-3 till delivery from 32 weeks. That is the suppressive dosing. That will reduce the viral shedding and need for LSCS. We can also give valcyclovir 500 mg 2 times daily from 32 weeks. Here in recurrent herpes, vaginal delivery can be done because the risk is low. Okay. Now, another thing that you have to understand is that whenever we give an option, so we recommend an LSCS, right? This is, at the end of the day, it is a decision of the patient as well. If she's someone who's strongly against a cesarean section, she would say, no, I want to go for a vaginal delivery. So in such cases, what would we do? Such cases, we usually give IV acyclovir and we monitor the baby closely. Okay. Now, primary herpes in labor. Now, if this patient comes to you and she's had that, that infection in the first, for the first time in during labor, and we do the history, we come physician, PCR virology, we offer cesarean section. Now, if she has had rupture of membrane, then some data says that if 4 hours have passed, the protective effect of cesarean decreases. However, it is still beneficial over a vaginal delivery. So in such cases, it is better that we expedite the delivery. Okay. And we can also give IV or cyclovir. Now, there are patients who present with primary herpes and who decline a cesarean section and want a vaginal delivery. In such cases, what do? We give intravenous or cyclovir 5 mg per kg every 8 hourly and subsequently to the neonate as well. That is IV or cyclovir 20 mg per kg every 8 hourly. This is important doses, please remember. For those who proceed with a cesarean section, especially where the membranes have already ruptured, in them also we would give intravenous acyclovir 5 mg per kg every 8 hours, and to the baby at 20 mg per kg every 8 hours. Okay, so when would we give? Primary herpes has come. She's not ever gotten treatment before. She comes to you in labor. She has a spontaneous rupture of membranes. Then what do? You give if she's going for a vaginal if she's going for a cesarean section. In the first 30 minutes, the older guideline said that we don't need to give the IV antibiotic, but then most of the cesareans would obviously take more than 30 minutes, right? So we would want to give the IV or cyclovir at 5 mg per kg 8 hourly, and then to the baby 20 mg per kg 8 hours. And also in women who deny a cesarean section with primary herpes in labor. Now, again, in recurrent herpes in labor, as I said, the transmission risk is almost zero. I'm sorry, this is not one, this is zero. The transmission risk is almost 0 to 3%. In such patients, vaginal delivery is preferred. So herein we have to explain the risk of risk and benefit of each form of delivery, and also emphasize on the point that the transmission rate is almost 0 to 3%. So we would recommend a vaginal delivery, but again, the final decision would always lie with the patient. Have you all understood so far, guys? We've read primary herpes less than 28 weeks, primary herpes more than 28 weeks, primary herpes in labor, and recurrent herpes in labor as well as in antenatal period. Please give me a quick thumbs up if you all have understood so far, because now I'll be talking about preterm premature rupture of membranes after this, and how to monitor the neonate. Okay, great. So moving on to preterm premature rupture of membranes. So that means anything before 37 weeks, right? So again, we have two options here. We have recurrent herpes and we have genital herpes. I'm sorry, primary herpes. In primary herpes, again, we know that antibodies are not there. If she's less than 37 weeks, it also depends on the gestational age, right? Before that, we have to understand that always this is going to be a MDT. Any form of herpes will be a MDT involving the obstetrician, the neonatologist, the gum physician. Management depends on gestational age. You give, because for prematurity, we would, if according to the NICE guideline, she fits into it, we would give the steroid and the MGSO4 for neuroprotection. And we'd also give the erythromycin if conservative and management is something that we want to do. Now, for example, she presents to you at, let's say, 30 weeks, and we are looking at the baby weight and we are thinking that, okay, maybe we can give a conservative management. Again, this is decided by the MDT. Here, we would want to give IV or cyclovir 5 mg per kg 8 hourly. This is the only place we want to give this. And with primary herpes in labor, what would we give? We would give IV or cyclovir 5 mg per kg 8 hourly. However, if immediate termination is advised less than 30 minutes, we don't need IV or cyclovir. And we know that if this is a primary episode and her delivery is planned within 6 weeks, then we would want to go in for a cesarean section. Okay. Again, this is something that would involve the consultant and the neonatologist and everyone, because it's again a risk benefit ratio. If the baby is near peri-viability, it's a primary herpes. It's again a decision of the patient as well as the MDT, right? In recurrent herpes, here, as I said, it has a lower risk again, very low risk of neonatal transmission, higher risk of comorbidity due to prematurity. We can go for a vaginal delivery, but what do we do here? Instead of IV, we give a suppressive dose of 400 mg 3 times a day till delivery. So if you all have understood this till now, we've always gone in for a conservative approach for recurrent herpes, and it's always been 4-3D, be it at term, okay, or if she presents, let's say, in third trimester recurrent herpes, we would start with we do the suppressive dose. However, if she presents in the first trimester, we do the suppressive dose from 32 weeks, right? And another thing that is there is that if she comes in labor, we would recommend a vaginal delivery. In preterm labor also, we start the 4-3D, that is suppressive dose till delivery. Okay. And we would here also give the steroid, the erythromycin, and the magnesium sulfate. Please note that where we give IV or cyclovir, we've given IV or cyclovir in this at this occasion where she's present with primary herpes with ruptured membranes, or with primary herpes with ruptured membranes, denying of vaginal delivery, or the cesarean is taking time. We would then give, and if she is presenting in preterm labor, preterm premature rupture of membranes, and she the cesarean, she delivers within 6 weeks. Okay. Moving on now. Women who have HIV. Now, women who have HIV, can you all hear me, guys? For women who have HIV, as I said, there's an increased risk of transmitting the virus. So what we do is for primary herpes, again, it is same as non-HIV. For recurrent, we would start 400 mg 3 times a day from 28 weeks. That's the only thing that we do for HIV. Rest of the things have to be according to the Viva guideline. That if her viral load is less than 50, we would go in for a vaginal delivery. If it's above 50, we would give her an option of vaginal or cesarean. And above, so it's basically cesarean recommended, but you can give her the option. And above 399, you would anyway go for a cesarean section. Now, neonatal care is something that is important. Now we will be providing you flashcards for this because there's a big table that's been given in the new guideline. So I will be providing that in the free group as well. But this is something that I want to quickly go over. Now, women who have had a baby, let's say the baby is born by LSCS, primary HSV in third trimester. So, but baby is born by LSCS. That means that's an okay thing. That is what is recommended, right? Primary herpes in the third trimester, we go in for a cesarean section. Now here the babies are at low risk. So swabs of the baby are usually not needed, no active treatment needed. Standard postnatal care including a neonatal examination at 24 hours of age. If healthy, feeding well, then they can be discharged. If at any point of time the baby develops, is lethargic, is not feeding well, poor cry, or you find any abnormality, fever, seizures, any form of sickness in the baby, we would want to evaluate the baby. However, if the baby has no problems, even at 24 hours, we could think of discharging the baby. And if the baby is born by LSCS. Now, again, women who have babies who are born in, like, let's say they have women who have herpes, primary herpes in the third trimester, and the babies are born within 6 weeks, and that too by a vaginal delivery. So we know that the transmission risk is almost 41%. So these babies are at a high risk. Okay. Now we know that the baby is at a high risk. Now, however, if the baby is well, then we take the SCOR swabs, right? That is the skin, conjunctiva, oropharynx, and the rectum, SCOR. The SCOR swabs are taken for herpes simplex PCR testing. However, the lumbar puncture is not done. Why? Because these babies are not at risk. These babies are not unwell. They are well. They don't have any symptoms. But we start IV or cyclovir 20 mg per kg 8 hourly. Why? Because as I said, she's denied her cesarean section and she is in labor and she has the lesions. So that is why we give the cyclovir. We give IV or cyclovir to the mother as well as to the baby. Implement strict infection control measures. These include washing your hands. If the breast has lesions, not feeding from that particular lesion, then proper care, proper hygiene of the baby. Parents should be advised to watch for and report any signs like infections like poor feeding, lethargy, fever, or any suspicious lesions on the skin as well. Now we have a baby who is sick, irrespective of the way the baby is born, right? Swab should be taken again from SCOR, that is skin, conjunctiva, oropharynx, and rectum. However, a lumbar puncture should be done, even if there are no CNS symptoms. And intravenous acyclovir is obvious. You should be starting it at 20 mg per kg every 8 hours. Babies born to recurrent herpes infected mothers, their chances of infection are low. Neonatal surface swabs are not necessary, does not require any active treatment. You have to observe the baby for 24 hours, see if it is healthy, feeding well. Parents should be taught proper hygiene and infection prevention strategies, and always give red flag signs. What are the red flag signs? That if there are any lesions in the skin, eye, or mucous membranes, lethargy, irritability, poor feeding, and fever, all of these present, then emergency medical care has to be sought for the baby. Okay, so let's just revise what we learned for the neonate. If patient is recurrent herpes, if the patient is primary herpes at in the third trimester and she goes for a vaginal delivery, here what would we do? Would we take the swabs, guys? Just tell me a yes or a no in the chat box. Primary herpes in the third trimester goes for a vaginal delivery. Yes, we would take the SCOR swabs, that is skin, conjunctiva, oropharynx, and rectum. Now here the baby, and obviously we give the IV or cyclovir. And if the baby is unwell, irrespective of whatever way it is born, we would send the lumbar puncture as well. And if the baby is born by primary to a mother who has primary herpes in the third trimester, but by LSCS, again it's just observation. No, even here there's no treatment. Okay, no active treatment. It is just observation. Here we give IV acyclovir, baby sick, we give acyclovir. If again baby is born to recurrent herpes mother, we don't do anything. We just observe and give red flag signs and infection prevention. Now, breastfeeding, if a woman is having herpes and her lesions are also present on the breast, then what do we do? Now, first of all, herpetic lesions on the breast can be mistaken as impetigo or eczema. In the presence of current herpetic ulcers on the breast, breastfeeding should be avoided from the affected breast and ensure that the infant does not touch the breast until all lesions have healed. Breast milk can be contaminated if it comes in contact with the active herpes lesions through touching the breast during hand expression or via the pump. Breastfeeding women and people should not feed the infant expressed breast milk from the affected breast either. So we don't feed from the affected breast and no expressed breast milk also. Herpetic lesions should be reviewed by a clinician to ensure that they have healed properly to confirm that the breastfeeding woman can resume. So she can't resume it on her own. You have to tell her that she has to come and see the gum physician maybe, and then be sure that these lesions have healed and then start. Some breastfeeding women may need additional support to maintain their milk production and may need to supplement with their expressed human milk. A first episode of recurrence of herpes on the breast should be treated with standard dose of acyclovir, because acyclovir is not known to affect the breast. Like it is secreted through breast milk, but it is not going to affect the baby in any way. Okay. So we're at the end of today's session, guys. I hope you'll understood about the herpes. If you'll have any questions, please type it in the chat box. We can discuss it. We will be providing you flashcards on the main tables in the guideline, and also a short as to how you manage a primary herpes and a recurrent herpes. Okay. Any questions, please type it in the chat box. Thank you, doctor. I hope all of you all have understood it. So the guideline per se is very redundant when you start reading it. But in the end, it means one thing as to when we have to give the treatment, when we have to not give the treatment, and when for a cesarean and when for a vaginal delivery. So I recommend and urge all of you all to make your own notes and write it down as to when you would do what, so that it becomes easier for you all to remember. The dose of the antivirals is important because that is asked, and even the neonatal management is asked. Okay. Doctor, the recording I think will be the backend team will be helping you. It will be available in the group, and the flashcards we will be also sending on the free MRCOG Part 2 group. Okay. So I will be taking your
Thank
leave
you
now,
so much.
guys. Any
Thank-
more questions? Yes, Dr. Nada.
I want to thank you. It was a very beautiful presentation and helpful.
Thank you so much. Um, Please feel free to contact us on the free group. As if you'll have any doubts, we can go over there. And give me a day. We will be posting the flashcard by tomorrow. So I hope you all to see in the hope to see all of you all in the free group, and just keep on studying and reading. Uh, Dr. Kosh, I can ask the backend team to help you out. No, that's no worries. Uh, you could contact someone from the backend team. Also, numbers will be posted for you all to get in touch, right? So just give us a moment. We'll be posting the numbers so that you all can get in contact with them. Any further questions, guys? Okay, so I'll just put in the number of the backend team so you all can definitely contact them.